everyone for joining. My topic's going to be on review of endothermal laser therapies. Prior to the late 1990s, vein stripping of the truncal veins and high ligation was a gold standard. There was a shift towards endovenous treatments, which happened in part due to the complications that occurred with the vein stripping, post-op infection, looking for ways to decrease morbidity, and also procedures with increased safety and efficacy as compared to the open surgery they were doing before. After the late 90s, early 2000s, the AVF, the Society of Vascular Surgery, considered endovenous laser ablation and radiofrequency ablation the gold standard for treatment of refluxing truncal veins. Laser ablation was first introduced in 1999, and the FDA approved it in 2002. So over time, since it's been introduced in 1999 and approved in the early 2000s, the laser ablation technology has evolved quite a bit. So the laser ablation technology is available in a variety of wavelengths in the near infrared spectrum. Wavelengths including 808, 810, 940, 980, 1064, 1320, 1470, 1510, and even 1920. The earlier technology used the shorter wavelengths, which was about from 810 to 1064. And as the technology evolved and we were using the longer wavelengths, these were introduced a little bit later on. The shorter wavelength, the 810 to 1064, is thought to target hemoglobin, myoglobin as the main chromophore for absorption, whereas the longer wavelengths target water in the vein wall. The longer wavelengths are thought to be associated with less pain and bruising after the procedure. We'll get a little bit more into that later on in the lecture. And the earlier studies, the earlier literature for laser ablation were mostly based with the use of short wavelength lasers and the bare laser tip, which I'll get into a little bit later on as well. And the main thing about moving into the longer wavelengths is that studies from the early 2000s, when laser ablation was first kind of taking off, there was a lot of post-procedure pain. They were using bare tip fibers, they were using kind of higher wattage in the shorter wavelengths, which led to a lot of bruising and just a lot of pain after the procedure. So here's a little chart here that what I was talking about in terms of the chromophores. Here on the very end, 1470 is what we use at CVR. As you can see, going across the wavelength spectrum, hemoglobin kind of is the main chromophore that's being absorbed. And then as you get to around a little over 1000, it starts becoming water that gets more absorbed, even more at the 1470, and even more as you go past, as they've been getting into the 1900s as well. So there's a couple schools of thought in terms of the mechanism of action of how laser ablation affects the veins. The first is the steam bubble therapy. The energy is distributed from the laser, which leads to blood, water evaporation, and transmitted heat injury. It's a process of convection, conduction, and radiation from the laser, which leads to kind of loss of the endothelium, and then there's an ensuing inflammation, which eventually leads to fibrosis. And this was first kind of touched upon by Dr. Posel. And then the second school of thought is the photomyelitic therapy or theory, which the laser ablation produces transmural vein wall injury, and typically is associated with perforations and carbonization. And the pattern of injury is eccentrically distributed, with the maximum injury occurring along the path of the laser contact. And this was touched upon by Fan and Rocks in their article with their mechanism of action for endovenous laser ablation. So energy delivery with laser ablation, mainly there's a couple different terms here, lead and EFE. And lead is the linear endovenous energy density. That's measured in joules per centimeter and depends on the power used in watts and the speed of the withdrawal of the device of pullback. Pullback is typically should be 1 to 3 millimeters per second to have a successful ablation while minimizing complications such as vein wall perforation. And the second term is the EFE, the endovenous fluence equivalence, which is measured based on surface area, and that's joules per centimeter squared, and has been proposed to be more of an accurate measure of energy delivery. This has been argued, but lead has kind of been used more in the literature since the early 2000s. So most of the literature kind of speaks on lead, but newer literature also talks about endovenous fluence equivalence as well. And there are multiple factors that affect the energy density. As you can see on this chart, the wavelength, which we kind of touched upon already, the power 5 to 30 watts, the energy per centimeter, 20 to 130, the delivery of the energy, whether it's continuous or pulsed, and also the design of the tip of the laser, which can be bare tip, jacketed tip, radial, or tulip. So this is a chart-based examination of Gsb occlusion rates using 810, 840, and 980 nanometer wavelength laser in earlier studies. As you can see across the chart here is the lead joules per centimeter, and up top is the Gsb successful ablation rate. And they have the lower leads on this side, the 23.4 to 60, the medium, and the higher leads all the way here at the end. And so the lower leads under the 65 joules per centimeter, initially a minimum lead of greater than 60 joules per centimeter was recommended by Thiba Kumar et al. And they were all using the shorter wavelength lasers. Timperman reported higher mean leads for successfully treated veins, 63.4, as compared to the leads used when the treatment failed, which is around 46.6 in their study, with an overall procedure success rate of 76%. And then one of the setters reported 94% closure rates using a low median energy over here for 23.4 joules per centimeter. However, this occlusion rate fell 90% over 3 months with early reopening. And then in 2006, Dr. Postel altered the lead also with the diameter of the veins that he was treating. And he recommended a threshold of 60 joules per centimeter for 10 millimeter diameter veins and 38 for 6 millimeter diameter veins. And they reported a 97% Gsb occlusion after 12 months. As you kind of go to the middle of the chart, 3 of the centers reported treatment failures using an average lead of 70 joules per centimeter, with treatments using a mean lead of no less than 80 joules per centimeter. There was a relationship between increasing the lead and the rate of procedure-related complications. And then towards the end of the chart, a study using the mean lead of 95 joules per centimeter resulted in 91% occlusion rates at 9 months with no complications. But the study that used 103 joules per centimeter noted that their 6-month occlusion rate was favorable, it was over 90%, but they had a lot of patients that were having moderate to severe pain, requiring analgesics. 12% of their patients in that study developed phlebitis and 6% developed paresthesia or hyposthesia. So as you can see, the occlusion rates overall in terms of their successful ablation rate is pretty high. Most of them are over 90% across the spectrum of the different leads that were used. But as you get higher on, it's good to have the good successful ablation rate, but as we get towards the end of the chart, there are quite a few patients who are developing moderate to severe pain. And so this chart is, as the first chart, that was more on the shorter wavelengths, and this kind of talks about 5 studies that use the longer wavelengths, the 1470, the 1510, and the 1320, and up to 100% closure rates at 6 and 12 months were reported with 1320, with a lead of 50 to 62 joules per centimeter. And 2 trials demonstrated success rates of 99 to 100% using the 1470, and they were using a bare tip laser, and their leads range from 72 to 83. And then the 1500 nanometer bare tip fiber achieved 95%. So all of them over 90%. As you can see with the longer wavelengths, the average lead was much less than what you need with the shorter wavelengths. So overall, there are improved outcomes associated with in the lead with the short wavelength lasers, around 60 joules per centimeter, and the upper limit around 95 joules per centimeter based on those studies. As we kind of look today with the longer wavelengths, we don't really go too high. Over here, they said that they achieved superior closure rates using a lower mean lead, less than 83, but most of the longer wavelength, the leads today are about 30 to 50 joules, whereas you can use 60 to 100 with the shorter wavelengths if you're still using those. But as you get closer to 100, and especially as you cross that 100 joules per centimeter mark, complications such as pain and paresthesia it increase pretty significantly. So here's a picture of some of the different types of fiber tips. So on the top left, there is the bare fiber, which they initially used when EVLA first started. And most of the studies before 2010 and before, the shorter wavelength, they mostly use the bare tip fiber. As you can see on the little diagram here, as the direction of the energy of the bare fiber, using the bare fiber, it kind of goes more forward. On the top right is the tulip tip, and that kind of goes more forward, but also with the way that it's designed, it can also have energy kind of a larger spectrum within the vessel. The never touch is kind of similar to the bare fiber, except it has this casing up front. And then the radial fiber, which instead of just sending it forward or in one or two directions, energy is shot off in a 90-degree angle, and you get in each direction, and you get more vein wall damage, not just towards the front or on two sides, but all the way around the fiber with the jacketed tip. So yeah, as I was saying before, fiber tips were initially used, and the jacketed tip lasers, based on the literature, have resulted in reduction of pain and bruising, as well as reduced ulceration and perforation. There's no definitive evidence, but there are increasing reports that these newer jacketed types are able to ablate GSVs at lower leads than the bare tip fibers. And on the left here, as you can see up top, there's a paper by Hirokawa, used 1470 for, used the bare tip and the radial tip, same wavelength. The power was around the same, 6 to 12 watts with the bare tip and 10 watts with the radial tip, same lead. And the occlusion rates, don't really differ too much between the tips, but the complications, you can definitely see with the bare tip, there was 7.4% with patients had pain, 19% had bruising. Whereas when you use the radial tip, 0.9% experienced pain and only 1.9% experienced bruising. And as you kind of go down a little bit, you're looking at 1540. Cavallini used the ball tip, 10 watts of power, follow up at 6 months, and had a pain percentage of 14% of his patients. And as you kind of keep going down, you kind of see the same pattern, the difference between the bare and the tulip and the bare and the radial, same wavelengths being used in these studies around the same energy. And you can see the difference in pain and bruising. The tulip and the bare are pretty similar, so they're going to have like similar in this study, similar pain and bruising. And then Panier 1470 nanometer wavelength radial tip. No pain after the procedure, no bruising after the procedure, 6-month follow-up. So as you go down, like I said, there is increasing evidence that the jacketed tip definitely has an advantage over the bare tip. So studies also suggest that the duration time of energy delivery may play a key role in laser ablation. So pulse wave lasers have reported fewer side effects and higher occlusion rates using lower energy settings than the continuous wave lasers. Using a lead of 60 joules per centimeter, Kanasaku reported no perforations or ulcers using a 1320 nanometer laser when compared with the 1470. And then also histological studies of EVLA suggest that leads should be chosen according to vein diameter. Dr. Postel was one of the first to kind of change the lead based on the diameter. As I mentioned earlier, he used a different, a higher lead for his between 10 and 6, the diameter of his veins. And then few studies of the effects of power, the wattage on laser ablation. There isn't too much literature on this. I tried to look around, but it does, looking through a few papers, does seem that the wattage above 25 watts seems to be related to higher post-op pain and analgesic use. So clinical indications for laser ablation, of course, having superficial venous disorder, reflux rate at 0.5 seconds, patent deep venous system. The vein has to be conducive to cannulation, and we want to make sure that the patient has adequate mobility. Relative exclusion criteria are arteriovenous malformations, restricted mobility, acute infection, acute DVT. And complications that occur with laser ablation include vessel perforation, phlebitis, DVT, infection, which is rare, skin pigmentation, neovascularization, paresthesias, skin burns, nerve injury, and pulmonary embolism. The incidence of these reported complications kind of varies between the literature. Skin burns on the lower end, and it's kind of similar when you compare it to radiofrequency ablation as well, less than 10%, 0 to 9%. Phlebitis 0 to 22% based on the literature, and paresthesia is also 0 to 22%. The most common of these complications are the superficial thrombophlebitis, nerve injury, E-hits, and most of the cases of the reported nerve injury are transient in nature. So in 2018, Dr. Healy did a systemic review and meta-analysis, reviewed the most serious complications of laser ablation, and reported 48 DVTs in 15,676 patients. It's 0.31%, 302 cases of E-hits. Out of 10,325 patients, that's 2.9%, three cases of BE in 8,200 patients, which is 0.04%. And most of these studies are just basically thermal ablation of the GSV. So in terms of outcomes of the endovenous laser ablations, the International EVLA Working Group reported long-term durability in 1,020 limbs with failure rates of 7.7%, 1 year, around 5% at 2 years, and 0 at 3 years. 2014 Cochrane review, Dr. Nesbitt reported a total of 8 studies comparing EVLA versus surgery in the 90s and treatment of great saphenous vein reflux. In terms of recurrence or recanalization, there wasn't much difference. There was more neovascularization in the surgical group. And of course, there was more rate of infection, pain, and analgesics post-op. The varicose-2 study demonstrated an ablation rate of 96.7% after 90 months for GSV ablation using EVLA with radial tip fiber, with improvements in quality of life scores, BCSS and ABVQ at both 6 weeks and 60 months. Most of the studies that you see report greater than 90% success rate for EVLA, and very comparable to radiofrequency ablation as well. In terms of like GSV and SSV, something that I want to point out is that most of these studies were based on laser ablation of the GSV. What I read about the SSV is some of the physicians who did some of these studies use lower leads in the SSV, but when they kind of compared the papers that ablated the SSVs versus the GSVs, it was actually the great saphenous vein that actually had a more successful ablation rate than the small saphenous vein. So one thing that I wanted to touch on was laser ablation can be used to treat pathologic perforators. Of course, there has to be at least C4, C5, C6 disease. Vein diameter has to be at least 3.5. Of course, it has to be pathologic reflux. The SECURE trial was a single-arm prospective 7-center non-blinded clinical study which examined patients with advanced skin changes or healed or active ulceration, mostly C4B, C5, and C6. And they specifically used the 1470 nanometer laser with radial fiber. The primary perforated vein closure, they did a 10-day visit, and the rate was 76.9%, a 95% confidence interval. And the successful primary closure rates at 1, 3, 6, 9, and 12 months range from 75 to 71%. And the percentages of patients with ulcer at screening to 1-year follow-up decreased from about 22.9% to 11.1%. So that's the end of the review of the laser ablations. Happy to take any questions. Thank you, everybody, for joining in.
So Sagar, you mentioned that the data for the SSV and the lasers is not as good as the GSV. I have to tell you, my experience has been the opposite. I've had more failures with radiofrequency ablation in the small saphenous vein than I did with lasers. I almost exclusively use the laser in this SSV. Also, even if you use the 3-centimeter radiofrequency catheter, sometimes there are technical issues with the SSV. So I almost exclusively use a laser for the SSV. But you are right, though. I'm old enough where this technology just started when I was practicing, and the lasers definitely do hurt more. You have to warn your patients that they're going to have some more post-op pain with the laser, and almost ask them to prophylactically take a non-steroidal and to wear their stockings afterwards for some pain comfort, though. Yeah, the other issue is the sural nerve injury and the SSV with the laser is higher than the RF, and that's true too. I've seen that as well. So any questions for Dr. Patel?
Just a quick question.
Sure.
Do you think the failure, some of the studies that I read said that the SSVs, in terms of comparing them to like the GSVs in terms of staying closed, do you think this is like physicians trying to avoid sural nerve injury, not getting the entire segment of the SSV has to do with possibly the literature, the findings that they found, even though you may have seen the opposite, the studies showing, do you think that has anything to do with that or not really?
I think the major problem with the laser is the pullback speed. If you pull back too quickly, you're going to get failures. If you pull back too slowly, you're going to get pain. And that's the problem with it. The other problem is if you're going to use the laser for the GSV and it's a long segment, you almost have to use a sheath because the GSV curves in the thigh and the bare tip fibers are inflexible and they can't get up there. So in my experience, my failures have always been with fast pullback speeds. So it's the trade-off. You either pull back quickly and get less pain, or you pull back slowly and get fewer failures and deal with the post-op pain. All right, so for those of you who are going to be applying for CMEs. I posted the SurveyMonkey link also, just to let you know the new process is going to be that on Thursday, Stephanie's going to email out the SurveyMonkey link ahead of time. So for some reason not able to post it in the chat, you'll have it in advance. All right. And if there's any problems with the SurveyMonkey link, just please contact Stephanie. We're sending out a new link every week to try to avoid the problems that we had last week with some people logging in. All right. So have a good weekend, everybody. And that's, I think next week is the VEITH meeting, so I don't think we have a lecture. All right. Good job, Sagar.